Our very first presenter will be Rich Caruana, who will talk about what friends should do when our friends use black box models. So Rich is coming up to the stage. Welcome. And without further ado, the stage is yours. I will leave, and let's hear Rich.
Maddie, thanks for the introduction. Oh, and thanks for everybody for showing up. Let me share my screen, and we'll begin the presentation. Hey, so hopefully while that's coming up, I'm Rich Caruana, a researcher at Microsoft Research in Seattle, and I'm going to talk about the risk of using black box models in healthcare and the importance of intelligibility, being able to see what machine learning has learned before you deploy it in healthcare. Before I do that, I just want to thank a lot of people who have worked with me over the years on this, including some great grad students, Yin Lu, Sarah Tan, Xuzhou Zhang, Ben Lengrinch, and Kingsley Chang, and then a number of other people from Microsoft and doctors from hospitals have also collaborated in this work. Here's how I got involved in this. Back when I was a grad student in the mid-90s at CMU, I was asked to train a model on a pneumonia risk problem, train a neural net. And the risk problem is trying to predict if a patient is low or high risk of dying from pneumonia. If you're low risk, the right treatment really is as an outpatient, you know, antibiotics, chicken soup, and call if you're not feeling better in a few days. But if you're high risk, about 10% of pneumonia patients die from it. You definitely need to be admitted to the hospital. And I guess I got very lucky. The multitask neural net I trained on this pneumonia data was the most accurate model that any of the many teams who were working on this data set could train. And the question arose, was it safe for us to use this neural net on real patients? Should we go and start using it clinically? And I decided no. And one of the reasons was a friend who was doing rule-based learning at a different university, but on the same data set, a year earlier had learned this funny rule, which said that if you had a history of asthma, it lowered your chance of dying from pneumonia. That is, asthma looked like it was protective if you had pneumonia. And that seemed very strange to us. It turns out, though, it's a true statistic in the data, even though the doctors told us that the asthmatics are at higher risk, not lower risk. And the explanation is that the asthmatics notice their symptoms of pneumonia earlier, they get to healthcare faster, and they receive very aggressive treatment. So, you know, they might try their inhaler or their med, it doesn't work. They call the doctor who treats their asthma, and they get really rapid, high-quality treatment because they're considered high risk. And that actually does lower their chance of death compared to the general population who doesn't get to care and high-quality care so quickly. Now, I just assumed if a rule-based system learned that asthma was good for you, well, the neural net I trained, which was even more accurate, probably learned it too, because it's a real pattern in the data. And you might think that that's why I was afraid to use the neural net clinically. Actually, it's not. I assumed that once I knew about this asthma problem in the neural net, I could probably fix it. What scared me was what other things might the neural net have learned that were equally wrong and risky, but I didn't know about them because something more interpretable like a rule-based system hadn't learned the patterns first and told me about things that I should worry about that might be hiding in the neural net. So that's why I was afraid of using the neural net. Now, before I go on and talk about our solution to this problem, I just want to tell you a little more about the problem. It's just standard statistical confounding. So what's happening is that having asthma is acting as a proxy for missing features. And in this case, the missing features are the time to care and the quality of care and type of care. And this problem is ubiquitous. There's always going to be important missing features that are not in your data. And in fact, time to care is something for pneumonia we don't even know how to measure. And yet it probably is the single most important factor in deciding whether you're low or high risk. And yet we don't know how to measure time to care for pneumonia because we don't know when you got pneumonia and when you first started having mild symptoms. Now, most data, you know, if we did a randomized clinical trial, this problem would be solved, but most data that we're trying to do machine learning on doesn't come from RCTs. Moreover, even if we wanted to do an RCT, we're never going to do an RCT for asthma, where we decide to sort of withhold high quality rapid care to half of the asthmatics to see if that hurts their prognosis. We would never do that, right? Because we know how to treat asthma and pneumonia. So it would never be ethical to even run the RCT that would solve this problem. And that means you just have to learn to live with data that is missing these important features. It means you have to live with confounding. And to drive this home, realize that the genome for most of us is not in our data yet. It's not in our medical records. Guaranteed our genome is very important for our healthcare. So there are very important missing features right now that we know probably won't be available in our medical records for 10 or 20 more years, and yet guaranteed the fact that it's missing is going to cause confounding on the features that we do have. So there will always be confounding, even features that we won't have available until sometime in the future. Maybe they're not even invented yet, lab tests that we don't even know how to do yet. Maybe those things will cause confounding on present day features. So it means you can't get away from this problem. You have to learn to live with it. You might think you could just clean the data and make the problem go away. I won't talk about it, but it turns out that's actually harder than what we're going to do. Our solution is going to be to try to understand the model trained on the data and be able to fix the model if we have to repair it. And I won't talk about it today, but if you're interested in race, gender, socioeconomic bias, it turns out this asthma effect behaves very much like a bias. And it's exactly the same problem for race and gender and socioeconomic bias. It's the data, not the learning algorithm, which is the source of the problem. And ultimately, you need to have techniques for handling this. Okay, so one solution would be to have a model that was as accurate as that neural net we wanted to use, but as interpretable and modifiable as like rules or logistic regression. But you may have heard that there's a trade-off between accuracy and intelligibility, that the most accurate models, things like neural nets and random forests and boosted trees, aren't very intelligible, and that things like logistic regression and naive Bayes and linear models, which are intelligible, just aren't very accurate on complex data sets. I'm happy to tell you that for tabular data, data where the features mean something to you, like blood pressure, or heart rate, things like that. It turns out this trade-off doesn't really exist anymore. We now have algorithms that are just as good as boosted trees and random forests in terms of accuracy, but they're even more intelligible than things like linear and logistic regression. You should be afraid, by the way, of linear and logistic regression models because they have to lie to you. They can't actually handle things like low body temperature is high risk, normal body temperature is low risk, and then high body temperature fever is high risk again. They can't handle things like this. And while you might understand body temperature enough to be able to engineer the data set and features to solve this problem, there are going to be other features that you don't know you have to do this engineering for. And it turns out the linear and logistic regression models will lie to you and say those features probably aren't very important. So you're going to want to use something like these EBMs. That stands for explainable boosting machine. I'll tell you about that. And these models really are a form of logistic regression on steroids. They give you intelligibility and accuracy at the same time. So now there are multiple papers now, be careful, I'm a co-author of this paper, so take the results with a grain of salt, that suggest that EBMs are just as accurate on many data sets as full complexity models. So for example, on these 10 data sets, the average accuracy of EBMs is 0.866. And yet if we go to the full complexity column on the right, the average accuracy of random forests is a little less than that, and the average accuracy of gradient boosted trees optimized to depth 3 turns out to be exactly 0.866 on average. So there's no advantage on average to using gradient boosted trees over the intelligible EBMs here. Here's a different study by Cynthia Rudin and her team at Duke. And they compared different glass box methods like ours. And the little arrows are pointing to our method. And if you look in 9 of the 12 comparisons, we're the most accurate glass box method, explainable method. And then I think we come in second on 2 out of the 12 and maybe in third place on 1 out of the 12. So we're the most accurate interpretable model currently available. And in their paper, they say they observed that the best interpretable models, the EBMs we're going to talk about, perform approximately as well as the best black box models, things like XGBoost. And I won't talk about this much, but we have a project with Jeff Hinton at Toronto and other people at Toronto and Google, where we're trying to make this intelligibility now be available not only in boosted trees, but also available in neural nets. So we're doing a thing called neural additive models, NAMs, which is the same sort of intelligibility, but in neural nets. But I'm not going to talk about that anymore. Okay, so let me tell you about these EBMs. They're a type of what's known as generalized additive models, which you may have heard of before. So the top here, I have linear models. So this is linear regression, an intercept plus a weight times a feature plus a weight times a feature. That's a linear model. At the bottom, we've got full complexity models. So this is just some arbitrary function of all the features. Think of that as being a neural net or boosted trees. There is something in between these. And this is what's known as an additive model. It's a function of the first feature plus another function of the second feature. Linear regression is a special case of this, where the function is restricted to be linear multiplied by a weight. But these functions can be nonlinear, multimodal, they can be very complex, but they are still restricted to being a function of a single feature plus another function of a single feature. So that gives them a lot more power, but it also is a great restriction compared to the full complexity models. And this is what makes these models intelligible. We can make that model class a little richer. So this is the sum of all functions of individual features. That's the line up above. But we can do a sum of functions of pairs of features, and now we can have pairwise interactions in the model to make it more complex. Or we could have three-way interactions in the model. What we're going to do is restrict ourselves to main effects and a small number of the most important pairwise interactions. And if we fit that well, we're going to get very high accuracy out of this model class. Now, we didn't invent GAMs. GAMs were invented in the late 80s by statisticians, Trevor Hastie and Rob Tibshirani. But they were very conservative when they fit these models. And because of that, they got lower accuracy and also surprisingly less intelligibility out of the models. They tended to fit them with a low order, very smooth splines. Now, we can't fault the statisticians for doing that. The late 80s, we didn't have the internet. We didn't have much computer horsepower. We didn't have large data sets. And most of machine learning hadn't been invented yet. So our contribution is going to put these GAMs on modern machine learning steroids. And in the process of doing that, we're going to get higher accuracy, very high accuracy. We're going to improve the intelligibility, and we're also going to get for free the ability to edit the models, which is great. And we've now released these things in a modern, easy to use open source package. So if you're already used to training random forests or boosted trees, it's now just as easy to train these models. So let me jump in and talk about this pneumonia data set for a while to get you comfortable with the models. And then what I'll do is I'll go through a number of other medical data sets and show you interesting things that we learned from data. Now, this pneumonia data set, it's pretty old. It's from 1989, and it had 46 features in it. So we know things about the patient, their age, their gender, if they have asthma or cancer. They've all had a physical exam, so we know their breathing rate, their heart rate, their blood pressure, what their breathing sounds like. They've all had a blood test, so we have results from the blood test. And then back then, using a chest x-ray was the gold standard for detecting pneumonia. So these patients have all had a chest x-ray that's been read by a radiologist, and we have the radiologist findings for that chest x-ray. By the way, we would not use a chest x-ray now for pneumonia because it's risky ultimately in the long run. But back then it was the gold standard. Now think about the model class. It's a function of a feature plus a function of a feature. We've got 46 features, so we're going to have 46 functions. And then we'll throw in 10 pairwise interactions, so we're actually going to have a total of 56 functions. From a high level, that looks kind of like this. Here's a function of age represented as a graph. Here's a function of asthma represented as another graph. A function of your blood urea nitrogen on the bottom represented as another graph. And the way you remember, there's 56 of these total in the model. And the way you use it is you find the patient's age on the x-axis, read off the y value, and write that number down. And that number is a log odd. So it's on a log scale. The more positive, the more it increases risk. The more negative, the more it decreases risk. +1 is a huge increase in log odds. That's a factor of E increase in odds of death. And a factor of -1 is a huge decrease. That's a factor of E reduction in odds of death. You add all these numbers together, and that gives you a score. And then you just convert this, the standard logistic regression way, to a probability of death by doing 1 over 1 plus e to the minus score. If this had been a linear model, this little score term would just look like a linear model. It would be an intercept plus a weight 1 times feature 1 plus weight 2 times feature 2. Instead, this little score looks like the sum of all these models. So if I could draw little tiny pictures of these models sitting here in this minus score term, it would just look like a series of numbers coming from graphs. So if this patient has a score of -0.78, that's a pretty high risk still. That means they have a 30% probability of death, which is actually quite high for pneumonia. You want to be a -2 or a -3 on the scale. So I'm going to zoom in and let's talk about age for a little bit so you get comfortable with these models. And then I'll show you a bunch of other results. The bottom is a histogram of our patients in this data set. Most patients are between 60 and 90, some patients in their 20s, 30s, and 40s, and a few patients out in their 90s and 100s. The top is what the model has learned about risk as a function of age. And it's important to realize this is not marginalization. The model is learning to predict risk as a function of age. At the same time, it is learning to predict risk as a function of all the other variables. So this particular risk plot is taking into effect the confounding effect of all the other variables. So all of these graphs work together. So let's read the graph. Remember, down is low risk, high is higher risk. So the lowest risk group are people under 50. And the model doesn't seem to distinguish between people in their 20s, 30s, and 40s, even though it could. It just says they're all equally low risk. And then patients in their 50s and 60s, risk goes up slowly. Then patient jumps up around 67, 68, 69. In the US, this is retirement age back in 1989. And what we're seeing is that patients who have retired are at slightly elevated risk of dying from pneumonia. We see this, by the way, in medical data sets in the US at least. A lot of things happen at retirement. You may have switched to Medicare. So your insurance provider may have changed. You might have moved to a retirement home in a different part of the country. Maybe you don't have a doctor yet, so you don't even have a healthcare provider yet. Maybe your daily activity has changed, so you're not as anxious to get to healthcare so that you can go back to work. So all of these factors, one way or another, contribute to a small elevated risk for patients who have just retired. Then risk goes up pretty rapidly, as you'd expect, as you become elderly, go into your 70s and your 80s. Interesting rise in risk right at 85, which is a very round number. I'm sure your body doesn't know you just went around the sun an 85th time and had your 85th birthday. So that must be a social effect. Kind of flat risk through the upper 80s and 90s, and then a really surprising drop in risk at 100, 101. We're pretty sure this rise in risk at 85 is because doctors, remember this data set's from 1989. Life expectancy in the US might have been around 80. So patients over 85 are really quite elderly. And we think what doctors are doing is they're giving little less aggressive treatment to patients over 85 compared to patients under 85. And the model's picking up on this increase in risk. So it's sort of like, you know, grandpa has a number of comorbidities, illnesses associated with being this elderly. Because of those comorbidities, grandpa now has pneumonia. The first or second round of antibiotics didn't work. Grandpa still has pneumonia, still has the other comorbidities. And maybe a decision is made, you know, maybe we're not doing grandpa any favors by continuing to fight. He has these other illnesses anyway. He's quite sick. Maybe it's better to allow grandpa to pass and to stop fighting. And we think basically doctors are just making a decision to give up a little more easily on patients who are very elderly and have other illnesses when those patients are over the magic number of 85. And I assure you, there's nothing in US insurance policy or healthcare policy that says you should in any way treat patients over 85 differently than patients under 85. We think it's just a subconscious decision about who is so elderly that it might be better to not keep fighting. Now, we think exactly the opposite is happening at 100. You know, if you've made it to 100, you're a centenarian. That's really amazing, especially back in the 80s. And we think what's happening is pneumonia is ultimately a treatable illness. And we think doctors are deciding we're just not going to give up on you. You've made it this far. We're going to go for the record. We're going to give you that third round of special antibiotics, fourth round. We're going to do everything we can to make sure that you get care so we can get you past this. And when I give this presentation to a medical audience, invariably a doctor comes up to me afterwards and says, you know, that's absolutely true. When a patient has made it to 100 and has something treatable, we really just don't like to give up. We really fight extra hard to save that patient from whatever they might have. Okay. Interesting thing about this model, we've been looking at just one of the 56 graphs, and many of the graphs tell very interesting stories like this. I mean, think about this story. Equally low risk under 50, low risk increasing slowly, 50 to 60, rise in risk at retirement. Probably true in the US, might be different in Europe. Risk goes up pretty rapidly in the 70s and 80s. 85 used to be considered a threshold for being elderly, and doctors were a little less vigilant above 85. And yet if you made it to 100, you got extra aggressive care, and we could see a sign of that. All of the graphs tell us interesting things like this, and yet this model is the most accurate model we can train on this data set. It turns out a neural net trained in the data set is almost as accurate. They're basically statistically indistinguishable, but this is actually the best model. So we got all of this interpretability without losing any accuracy, which is really amazing. Okay, we got something else as well. We got editability. How many people think that a patient who's 105 is really actually lower risk than a patient who's 95? I don't believe that. I think it's just the extra care that the patients over 100 are getting. We can edit this model. The model really is these graphs. So we can edit the graph, and if we make risk go monotonically up, say past age 85, the model will have to do that because we're ultimately in control. Now, you have to be careful anytime you decide to overrule the statistics in your data. You better know why you're doing that and do something that's good when you overrule it. So you have to trust the doctors when they explain why risk is going down over 100, and you have to trust that this line they're drawing is reasonable. But we believe this would make the model more safer, more appropriate to use if we deployed it. And by the way, when we do this, accuracy on the test set goes down a little bit. And that's because in this case, the test set is just a random sample from our training set. So it's also true in the test set that patients over 100 look like they're lower risk. So now we make this edit, our accuracy on the test set goes down, and yet we believe the model will be more accurate and safer to use in the real world. So that's an interesting problem. However, if you were an insurance company and your interest was only actuarial, you don't need to edit this model at all. You're not going to intervene in someone's care. So you just, if the patient's over 100 and is a better chance of surviving, you want to know that so you can keep more money for their future health care. So it really depends on how you're going to use the model, whether you need to edit it or not, whether the model is right or wrong. So there's no such thing as a model that is good or excellent if you don't specify exactly how the model will be used, how its predictions will be used. Let me show you some things this model learns. There are jumps at round numbers all over the place. They're almost always due to human social policy effects. There are very few phase changes in the social and physical world. Of course, remember we started that a rule-based system had learned that asthma was good for you. This model also learns that asthma is good for you. The asthmatics are on the right, and notice that risk goes down about 0.18, which is not trivial. So the model thinks that asthma is good for you. But the model thinks that other things are good for you too. The model thinks that having a history of chest pain and heart disease are also good for you. So the risk also goes down, and it's additive for these two effects. So actually the risk goes down about -0.4 for having heart disease. Even worse, the model thinks that having a kind of wheezing, which indicates that you have a lung obstruction called stridor, is good for you. And that can't possibly be true. Stridor means that your pneumonia is actually quite advanced. That's not good for you. And yet the model thinks that's good for you. Why does the model think that being over 100, having asthma, having chest pain, heart disease, and now an obstructed lungway are good for you? Well, it thinks these things are good for you because all of these patients get to care faster or get higher quality care. The asthmatics, remember, get to care very quickly, and then because they're considered high risk, they get very high quality care. The heart disease patients confuse the early symptoms of pneumonia with a possible heart attack. So they get to the ER very, very quickly. They get to the front of the line. Within seconds, they know it's not a heart attack. And then they realize it's pneumonia. They have a history of heart disease. They're considered high risk for pneumonia. So they get incredibly high quality care because they're already in the emergency room. And the stridor patients, it turns out their symptom is so noisy, the wheezing is so bad that the patient knows, and everyone next to the patient in the meeting or in their family knows that they have to go to the hospital to get care. So if you have a symptom from a disease, you really want to have a symptom that you can't ignore, that forces you to get to care early, and that will actually make you ultimately lower risk if the disease is something that's treatable. So now what do? Remember, the model's additive. It's going to predict that a 105-year-old patient with a history of asthma, who has a history also of heart disease and recurring chest pain, and who now has an obstructed lungway, it's going to predict that this is an ultimately very low-risk patient, because all these things are additive towards low risk. We don't want the model to do that. So one of the things we can do is redraw these graphs and just eliminate the effects by making the graphs flat. More likely, a doctor will tell us, no, the asthmatics are at elevated risk, add 0.3, 0.4 to their risk. The people with chest pain are at even higher risk, add 0.6 to their risk. And man, if your pneumonia is advanced enough to have stridor, that's very high risk, add 0.8. So in these cases now, the doctor is clearly overruling the statistics in the data. They're using medical expertise to redraw this part of the model so that it's safe to use the model clinically. The worst thing, though, about this is that the model is rewarded with extra high accuracy on the test set, remember, for predicting that these patients are lower risk. And the accuracy, again, is going to go down when we change the model so that it starts predicting that, in fact, these patients are higher risk. That means accuracy is not the gold standard in machine learning. I know most of us who do machine learning have been trained to think accuracy is the thing we should always maximize. That is not the case. Accuracy can be very misleading, and models can be rewarded with extra high accuracy for doing things like this, which are actually very risky and would possibly harm patients if deployed clinically. Now, I've been telling you some terrible things that the models have learned. I want to show you that there's some beautiful things you can see in these models. 90% of what they learn is good. 5% is amazing new information. And then only maybe 5% of what the models learn is bad and needs to be corrected. So this is your blood urea nitrogen level. It's a blood test we've all had. And doctors really like this graph because they could see the effect of their treatment. So doctors start to treat high blood with a medication right at 50, and notice risk goes up to 50 and then immediately flattens off. And that's because the medication is effective. And then at 100, they start to treat with dialysis. Notice risk goes up to 100, and right at 100, risk starts to come down. And that's because by 110 or 115, all the patients are getting dialysis, whereas the patients at 90 probably weren't getting dialysis. Now, the model has detected this, but doctors were always also concerned that, risk is pretty high at 40. Maybe they should be treating with a medication at 40 if it's a safe med, instead of waiting to 50. And it's really tragic that patients who have a high BUN of, say, 110 or 115 are actually lower probability of death than healthier patients who have a BUN of only, say, 90. So that's a shame. With this kind of model, we're able to treat it like a spreadsheet because it's additive. And we can conservatively draw this line, this red line, that says that if we were to treat with dialysis, not waiting to 100, but say starting at 85, then we believe the risk curve would actually be under this red line. There's a reason to believe that this is a conservative line, in part because it joins over here at 115, where all the patients are probably getting dialysis. And now the area between the red line and the green curve is lives saved. Pneumonia is a pretty big disease. There's about 6 million cases per year in the US. So it turns out that just making this one change to this one treatment threshold for dialysis for one lab test, blood urea nitrogen, can save as many as 2,500 lives per year in the United States alone. So if you do that, worldwide, it can have quite a big impact. So you really can learn some amazing things from these interpretable models. And I just want to show you that these treatment effects are everywhere in data. This is systolic blood pressure. Notice that there are bumps happening at a lot of round numbers. Here's a bump right at 140 to 150, which is considered a signal of high hypertension. Notice there's a bump right here at 120, which is considered the onset of mild hypertension. Notice that there's a peak just past 175, a peak at just around 200, a peak around 225. All of these things are happening at round numbers. If we go back to blood urea nitrogen, what are the odds that the right treatment thresholds for BUN were 50 and 100, two incredibly round numbers? Well, the odds are 0 that those are the right answers. They probably should be more like 40 and 85. And we see exactly the same sort of effects here. So we see this all over the place in medical data. Every time you train a model on medical data, it is learning these things, but you don't know about them because your model is not interpretable. Let me show you a pairwise interaction very, very quickly. So this is risk as a function of age on the left. We saw that before. This is risk as a function of cancer on the right. This is a new graph for pneumonia. And as you might expect, having cancer does add considerably to your risk. But there are some things that you can't model as a number from this graph plus a number from that graph. You really need, if you think about parity or exclusive OR, you have to have both bits at the same time to have any information. This is an interaction. We have cancer on the x-axis, age on the y-axis, and the z-axis, the color, is telling us risk. Notice this group of very high risk yellow down here in the bottom right. These are very young patients who have cancer. Why would young patients, who are normally considered very low risk, look like they're extra high risk? Well, it's because we treat cancer in young people extra aggressively. And it's such an aggressive treatment that it often knocks out people's immune systems. And if you've got pneumonia and your immune system has been knocked out, you really are at higher risk. And the model is basically recognizing that we've been hitting the youngest patients the hardest with treatment, having the biggest impact on their immune system. And the model is saying in this interaction, there's a special group of very young patients who have extra high risk just because of their youth. In this case, because of the treatment they received because of their youth. And the model is recognizing that and trying to add a correction to the model. So now let's go to a different data set. This is ICU mortality. And this is what's known as PF ratio. So we're trying to predict your chance of dying if you're in the ICU. This is how well you're breathing. Low PF ratio means you're having a lot of trouble breathing. And notice the difference here is +1 compared to about a -0.3. That's a 1.3, 1.4 difference. That's a big effect on an odds ratio graph. That's an effect of about 4 to 1 increase in risk, a terribly large effect. The graph looks reasonable. Notice we see jumps happening at round numbers. Around 200 is a very clinically important number. 700, 750 is a clinically important number. What's happening here at this point in the graph? That's very weird. The risk here is as low as the risk for the healthiest patients. So what's going on at that place? When we saw this graph, we liked the rest of the graph. We just didn't understand that. We thought it might be a round number. It turns out it's 323.6. That's not a round number. We thought it might be a round number in metric units converted to English units. Turns out no, English units are the natural units for this data set. Then I asked the question, well, what's the mean of this feature? We really were grasping at straws at this point. And it turns out the mean of the feature is 323.6. So this funny blip in the graph is happening right where the mean is. And then I asked, wow, were there ever missing values in the data set? And if so, might they have been imputed with the mean? And someone else knew about the data set before it had gotten to us. And sure enough, there were 60% of the patients are missing this value. They didn't bother to measure the blood, the FP ratio blood test, and they didn't bother to measure it because you seem to be healthy. So now we've got 60% of the patients who are very healthy sitting at the mean of the feature when it is measured, which turns out to be 323.6, which is a moderately high risk region in the graph. So we have a bunch of healthy people over here in an unhealthy region, and the model is doing everything it can to predict that they're low risk. Because of that, it's still pretty accurate. The problem, though, is that there are patients who really are a PF ratio of 323, and they're going to get predicted as being low risk as well, which we don't want the model to do that. So we have to change the way we handle missing values so that this effect goes away. And sure enough, if we do missing values a better way, this problem immediately disappears. So you can see how in this case, intelligibility has told us something about pre-processing that someone else did to the data set before we ever got to the data set. And it immediately showed us a problem that we knew we had to fix before we were going to consider using such a model clinically. I'm just going to do this briefly. When we train our model, it says that having AIDS, HIV, is actually pretty low risk for being in the ICU. And yet there's a SAPS model from the 80s, which says that no, having AIDS is the highest risk thing that's possible. So we had a doctor who created this data set on the call with us. And the doctor said, what's happening is that the SAPS model is from the late 80s. And back then, AIDS was the kiss of death. It was a terminal illness. We didn't have any treatments for it. And if you were in the ICU, there's a good chance you were in a terminal phase of HIV. But this new data set, this MIMIC2 data set, is from circa 2005. By then, HIV is a very treatable illness. And what we're seeing is that If there are many reasons for you to be in the ICU, HIV is not one of the worst reasons. So in fact, the model thinks that it's better than other reasons and gives it lower risk. So you can see that data and models can get stale. And in this case, healthcare made huge advances on treating AIDS in just the space of, say, 25 years. And you really do have to change this old model, which is still in use, to something more like this new model. Let me talk about severe maternal morbidity. This means that something bad has happened to the mother during delivery. Say the mother has a hemorrhage, needs a hysterectomy, has an embolism, needs a severe blood transfusion, things like that. And the usual factors that an obstetrician will tell you are factors about the mother that make her higher risk for severe maternal morbidity. This would be things like maternal hypertension, maternal diabetes, high maternal age, high maternal BMI. It's going to turn out, when we train a model on the data, it completely disagrees. The model tells us this: the two most important factors for the mother's health during pregnancy are the size of the baby and the size of the mother. The size of the baby is mass. So this says that the larger the mass of the mother, the higher the risk. And this is a huge difference, 1 to 2. Remember, this is a log scale. This is a huge increase in risk as the baby gets larger. We also see a significant decrease in risk as the mother gets taller, which is the best measure we have of the size of the pelvic opening of the mother. And the model is basically telling us, you know, it's simple physics here. If you have a small baby coming out of a tall mother, that will be easier on the mother. But if you have a large baby coming out of a small mother, that will be much harder on the mother and cause increased chance of morbidity. So we created a new BMI. BMI is usually your mass divided by your height squared. We created a new feature, which is the baby's mass divided by the maternal height squared. And when we create this feature, it immediately becomes the single most important feature in the model. So we think this is going to be very important going forward. Let me talk briefly about COVID-19. This is risk of dying from COVID-19 as a function of age. Very similar in many ways to the pneumonia graphs. We have a lot of flatness in risk out in the 20s, 30s, 40s, 50s. We see jumps happening at round numbers, 55, 65, 70, a jump at 85. These are all things where it's common to see. Here's a surprising thing. Notice that risk doesn't go down at 100. If anything, risk is going up dramatically at around 95. And that's because many of these patients are on do not intubate orders. We've decided to not give this incredibly invasive, aggressive, and risky treatment to the very oldest patients. And because of this, they're not at extra low risk, they're actually at somewhat elevated risk. This model is very similar in many ways to the pneumonia model, another respiratory illness. The interesting thing is the vertical scale, though, is much larger. This is a difference of almost 2 points. That's 4 times larger than what we saw with pneumonia. So COVID-19 is a much riskier illness than pneumonia, as of course we all know. This is gender. Women are at lower risk than men, as is often the case for respiratory illnesses and illnesses associated with being elderly. Men are the weaker of the sexes. What's surprising is just the difference. It's a difference of about 0.4 points, which means if a woman had a 10% chance of dying from COVID-19, the man might have a 14% chance of dying, which is a really large discrepancy that we haven't seen before in this sort of illness. We had some early data back in March, which let us detect things like kidney disease, diabetes, and hypertension were very high risk, and things like cancer and COPD and asthma were not. But now we are working with hospitals in New York City, which sadly was ground zero for COVID-19 in the US back in April. And now we're able to learn much more detailed models. These are just medications you take before being admitted to the hospital. Let me just show you one, these platelet inhibitors. These are meds that you might take, like low-dose aspirin because you have heart disease. And it turns out they lower your chance of dying from COVID-19 if you were admitted to the hospital. And that's because they prevent clotting. And one of the ways of dying from COVID-19 is from clotting. So it turns out that having been on heart disease medication prior to being admitted to the hospital for COVID-19 is good for you. That's one of the reasons we think why heart disease doesn't look like it's a high risk factor for COVID-19, because of the treatments the patients were receiving. Down here, though, at the very bottom, these proton pump inhibitors, wow, that looks like a med that's really high risk. And the doctors tell us, you know, the med itself probably has no effect on the risk of the patient from COVID-19. What's probably causing these patients to be higher risk from COVID-19 is the illness that they have that's causing them to get the proton pump inhibitor. So you have to be very careful when interpreting these graphs. In this case, for platelet inhibitors, we think it is the med that is conveying the change in risk. Whereas here, we think it's not the med itself that's causing the increase in risk. We think it's the illness that you have that's causing the increase in risk. We had an interesting discovery in the very early days. This is the first month of COVID-19, back the first week of April. Everyone knows that high lymphocytes is a risk factor for COVID-19, but the doctors thought it didn't make any sense for low lymphocyte patients to be at very high risk. So we even ignored this finding at the time because the doctor said it just didn't make any sense to them. There are now multiple papers that have been published that say that extra low lymphocytes is also an important risk factor for COVID-19. And it seems to suggest that the patient is not mounting an adequate immune response to COVID-19. So we think that this is actually a sign of some sort of impaired immune system, or at least an immune system that is not well tuned to COVID-19. I'm going to skip hospital 30-day readmission. Let me just very briefly do it. It'll only take a second. I just want to show you, we can make predictions for individual patients and understand them as well. Here we're trying to predict if a patient's going to be readmitted to the hospital in 30 days. There are 4,000 graphs in this model. I have never looked at every graph. We're not going to look for each patient at 4,000 graphs, but because each graph creates a single number for each patient, we can sort those numbers by how much they add to a patient's risk. So here's a patient with a 92% chance of being readmitted. The single most important feature out of 4,000 for them is that they're getting fat emulsions as an IV. We're putting calories into the patient through an IV. The second most important feature is from the doctor's notes. They have what's known as cyclical vomiting syndrome, and it's been mentioned 16 times in the doctor's notes. That really increases their risk a lot. It turns out they're getting a med, which is amitriptyline, which is an anti-nausea med, and that increases their risk a lot. They've been an inpatient 64 times in the hospital. That's incredibly large. It's the right end of the graph here. Notice the graph is an incredibly beautiful, like smooth monotone graph. The model doesn't have to learn monotone increasing functions, but it did in this case. And then they've been in the hospital 18 times in the last 12 months. So obviously their chance of coming in the next month is pretty high. Here's a completely different patient. This patient's been in only 6 times. They have a history of codes which suggest that they're not as careful of their health, or maybe they're even suicidal. They've been in the ER 6 times, so all of their visits have been through the ER. They're listed as having combat fatigue, so perhaps this is a vet, and they have mild drug intoxication. Now here's the interesting thing, 2 very different patients. And yet, I think you can see that by just looking at the top 5 or 6 graphs, we can tell that those 2 patients are incredibly different, that their stories are really completely different. Okay, I'm going to go back, and we're just going to end the presentation now. Sorry, I've already done that. Okay, high accuracy on a test set is never enough, and especially in healthcare and other mission critical domains. It's actually usually misleading. You think you have high accuracy. I guarantee you, you don't. All models have the kinds of problems in them I'm showing you. And models are rewarded with high accuracy for doing things that are very stupid and very risky that you will recognize immediately if you're able to see the model. And retrospective analyses where you're using a test set, it always leads to optimistic test set accuracy. You really need to ultimately do prospective analyses in healthcare before you go public with a big treatment. And there are treatment effects in all of your data. I guarantee it, because patients are receiving care. So the effect of that care is influencing what your model is learning. So the data is always going to be wrong in surprising ways that you can't anticipate. And these new models really give us very high accuracy, intelligibility, explanation for individual predictions, and the ability to edit the models. And here's a pointer to the open source package that will let you use these things. I'll put that up later on a bigger page. And you might think you can get higher accuracy by removing these features like heart disease. You can't do that. It turns out you have to keep these features in the model because it'll still learn these bad effects through correlation with other features. And now it will learn it in a way that you actually can't detect. So you need intelligibility, transparency, and explanation to use ML safely in healthcare. And here's a pointer to the open source package. If you just look for my name or for interpret ML, you'll get to that package. Okay, I'm going to stop presenting now and go back. If there's time for questions, I'd be happy to take them.
Yeah, thank you very much. And I will take my position to ask the first question. And my first question is that so accuracy, you mentioned, is probably not the best or not always the best evaluation metric. So we have a couple of evaluation metrics, and there are guidelines like when do you want to use some of them. But can you give us? I don't want to use the guideline, but some bullet points on how.
Sure.
Choose one.
Let's see. So first of all, what you really want is a model that's high accuracy and intelligible. You should be afraid of models that are low accuracy. A model that has lower accuracy, like a linear or logistic regression model, yes, it's intelligible. The problem is it can't model the phenomena correctly. And because of that, it will lie to you. So there are features where it needs to do a U-shape or a hat-shaped curve. It can't do it. So it'll do a low slope horizontal line, and it'll tell you a feature is not important when in fact it's a very, very important feature. Or even worse, because it can't fit a nonlinearity in some feature properly, it'll change what it does in another correlated feature. And you'll even see effects on other features go from being positive slope to negative slope or negative slope to positive. Like it'll actually misrepresent what's in the data. And that's because it's incapable of adequately representing the phenomena in the data. So ultimately what you want is the highest accuracy model that is also going to be intelligible. And right now that's these EBMs. Maybe next year it'll be something else. Like we're working to make neural nets be even better than this. So maybe next year you'll want to use NAMs instead of EBMs. But you definitely want high accuracy. But you want intelligibility. Here's another metric. Often people want sparsity, which is use the minimum number of features. Doctors are very biased to using the minimum number of features they can to get high accuracy. It turns out for intelligibility, you actually want to use the most number of features that are consistent with high accuracy. And that's because if you use the fewest number of features, what that means it's doing is it's taking all the correlated effects from other features that you're not including in the model, and it's compiling them into the features that you're keeping. Like lots of things correlate with age. So your age graph will get very complex, and you'll never actually understand all the detail in your age graph is actually coming from this correlation with heart disease and a correlation with blood pressure and a correlation with having this illness and cancer treatment that you had 5 years ago and things like that. You'll never know, but they'll all get compiled into this age graph because all those other features got features selected away. A model is much more interpretable, surprisingly, if you keep all of those effects in the model and you let the model do its best to learn the retirement effect on the retirement variable, the you had chemotherapy treatment 5 years ago effect on your prior treatment variable, the effect of your blood pressure on your blood pressure variable. So a sparsity metric, which I think many of us have been taught to favor, is not a good metric for intelligible models, especially in healthcare.
And now that you mention interactions, we actually have a really good question that I was also wondering that you showed us, like what the model thinks about a certain interaction. You showed us a really interesting chart. And there's a big question that how do you select what features you evaluate as interactions, either as a pairwise or as a more complex?
It's a great question. I, of course, didn't talk about that. So statisticians traditionally would have only looked for interactions in the most important main effects. That is, the most important features. They would look for interactions in just those important features. We actually sift through all order n squared possible interactions. And we have a heuristic for sorting them and finding the ones that look like they're most important to the model. And then you get to say, well, use the top 10, use the top 20. you get to tell us how many interactions you're willing to accept in the model. Usually we find that it is a very small fraction of the n squared interactions that's important. So just as feature selection usually says that there's most importance on a small number of features, interaction detection, since most of the effect is actually in the main effects and not in the interactions, it turns out on most data sets, you actually get away with just a handful of important interactions, maybe a dozen interactions. The most interactions I've ever included in a model is 200, and that was in that readmission model, which had 4,000 features. So if you think about it, there's roughly, what, 4,000 squared, what's that, 16 million?
It's more than
over 2 interactions, right? There's 8 million interactions or something like that. And we only included a very tiny fraction of them, and that's all we needed. Yeah.
Yeah. Well, that's really interesting. And maybe a shorter question to the end.
Sure.
For EBM and for interpretable ML, is there an R package in the works? Or
it's a great question. We have released what you might call a baby R package. It has just the very simplest form of EBMs in it. I'm sorry, it hasn't caught up yet to the package that we have that's Jupyter Notebooks and Python. The R package is not as mature yet, but you can do very basic main effect fitting with EBMs now in R. It's not great. We are working on it, but it'll probably be 6 months before I think it has enough functionality that I would recommend it to you. If you want to use that to try EBMs, go ahead and try it, but it's going to be awkward to use and it's not going to be full featured. And if you like the EBMs, then you should immediately, sadly, switch to Python and use the Python package because it has much more capabilities. It'll also be much faster and easier to use. And I apologize for that. We know GAMs came from the statistics community, and yet because we're ML people, we did Python first. But we know we need to ultimately get it to the R community. That's
really, yeah. But also the R people are really handy and capable to use a lot of things, because people who use R, they're already very hard.
Yes. And by the way, there are other GAM packages out there. There's PyGAM and things like that. In all modesty, you should use EBMs now. It is the highest performing GAM algorithm that's available right now. And as I said, we're working hard to replace it with something new, next year that's based on neural nets. So but right now we are the best GAM algorithm available. And I've had the luxury of even sitting in Rob Tibshirani's office down at Stanford, and spending an entire afternoon and telling him about all the things we did to what he and Trevor Hasty, invented 30 years ago to make it better. And I just had a blast telling Rob about all this stuff.
All right. I know I have to leave, so I don't want to keep, but it was super interesting, and I can really just thank you for being here. It was, I made a lot of notes. So thank you, Rich, and great presentation.